Okay, good evening everyone. So let me know if audio, video, everything is fine. Has everyone joined in? If everyone is here, we can start the session. So let me know if the audio, video, everything is fine and if you people have joined in so that we can start with our questions. So we will try to make this as an interactive session. All right. Good evening, Monirudha. We'll try to make this as an interactive sessions. All right. The questions are being displayed. I'll read out the questions along with the options for all of you. Okay, you can take 2 minutes to process everything and let me know your answers. And then I will tell you the answer to the question and how we arrived at the answer. So in this process, we are going to learn how to approach a question and what all things we need to keep in mind, all right, while coming to the conclusion or to the answers. All right. So let us start. I'll read out the first question. A dental surgeon accidentally creates an orodental communication while extracting maxillary first molar. Which diagnostic test will you carry out on the chair to establish the presence of a orodental communication? All right. So the option A is Valsalva maneuver, B is transillumination, C is irrigation, and D is PNS view. Okay. So these are your 4 options. You all can quickly go through this question and let me know the answer, and then I'll tell you the correct answer. Okay, I want everyone to participate. All right, whosoever are viewing are present live with me. It's okay you make mistakes over here. All right, because if you will make mistakes over here, only then will you do the correct thing in the exam. So don't be afraid to give the wrong answer to me right now over here, because it is absolutely okay. Everyone is at the same level. No one is superior, no one is inferior. Everyone has to learn, everyone has to practice. All right, so please don't be afraid. Tell me your answers so that the corrections can happen and you people can become more confident. I want more answers, please, from students. Okay, so the here now option A is Valsalva maneuver, option B is transillumination, option C is irrigation, and D is PNS view. All right, so we will first eliminate PNS view on chair. Anyways, on PNS view we are not going to see a orodental communication. All right, first reason to exclude this option is we are not going to see a orodental communication on PNS view. All right, and the second thing is PNS view anyways cannot be done on the chair. Fine. Now B, transillumination, option B, transillumination is also ruled out because it is for establishing sinusitis, maxillary sinusitis, but not orodental communication. So now the confusion remains between option A and option C. Now you have to, in between these two options, zero down on the correct answer. So Valsalva maneuver. What is Valsalva maneuver? Blowing off air against closed nostrils. Okay, it is blowing off air against closed nostrils. Please understand, it is a maneuver, but it is not a diagnostic test. Once this maneuver is going on, then you do the diagnostic test. Then you hold a mirror, then you look for bubbling of blood in the socket, then you look for fogging of the mirror, then you look for displacement of cotton or paper from the socket. All right, but Valsalva maneuver is not the diagnostic. It helps in diagnosis, but it is not the diagnostic test. Option C is, so Valsalva is also ruled out. Option C is irrigation. You take a saline syringe and you irrigate the socket. Alright, you irrigate the socket and you look for exit of your irrigant from the nasal cavity. Alright, you look for exit of the irrigant from the nasal cavity. So this is your answer. I'll again explain Valsalva maneuver and between irrigation. So Valsalva maneuver you do, alright, you ask the patient to blow against blocked nostrils, okay, and when this is happening, you will look for bubbling of blood in the extraction socket, fogging of mirror, displacement of cotton, or displacement of paper. But in irrigation, you will take a syringe filled with saline, irrigate the extraction socket, and look for exit of irrigant from the nasal cavity. Alright, is it understood by everyone? Okay. Now, surgery for lip correction in bilateral cleft lip palate is done at. Okay, surgery for lip correction in bilateral cleft lip palate is done at. Option A is 18 weeks, B is 2 to 3 months, C is 4 to 5 months, and D is as soon as possible after birth. So if you could all tell me the answer to this question. Okay, great. So the second question, please tell me the answer to this question. Okay. All right. Now, see, you have to remember this is a factual question. So lip correction is always cleft lip. Okay. Now, the thing is, even if it is bilateral cleft lip palate, unilateral cleft lip palate, whatever it is, your cleft lip will always, lip correction, only and only lip correction I'm talking about. Lip correction will always be 10 weeks. Alright, it has always, whether it is bilateral, unilateral, it has always got to be 10 weeks. Okay, so what is 10 weeks? 10 weeks is lies between your 2 to 3 months. Okay, 4 weeks in one single month, so in 2 months is 8 weeks, so your 10 weeks is somewhere between 2 to 3 months. All right. Okay, cleft lip correction only, so the answer is 2 to 3 months. Understood? Is it clear, all of you? So we'll go to the next question. So this says, question 3, which of the following are indications for removal of reconstruction plates from surgical site? Loose plates with draining sinus, exposed plates, malposition and rotation of plates, and secure plates. So option A says 1 and 2, option B says 1 and 4, C says 1, 2 and 3, D says 1, 2 and 4. Okay, so I need the answers from all of you. Take 2 minutes, take a few seconds to go through these options and then tell me the answer. Okay, so now let us see. In loose plates with draining sinus, yes, you will remove the reconstruction plates because this is infected hardware. Okay, exposed plates, that means exposure in oral cavity or exposure extraorally, whatever. Malpositioned and rotated plates, plates who have deviated or shifted from their original fixed position. Okay, apart from this, where you have to remove the plates, they can be broken plates. All right, broken plates, or in some people, in some patients, over a period of time the plates can become more prominent. All right, in that case also you can, it is a relative indication to remove the plate, but it is not a absolute indication. Suppose where the plates have become a little prominent, you can remove them. But secure plates, when they are present in their original fixed position, you don't need to remove them. All right, so your option C, 1, 2 and 3 is the correct answer. All right, and so your loose plates, your broken plates, exposed plates, this is all collectively known as failure of hardware or hardware failure. All right, this is known as hardware failure or failure of hardware. Now you will see how you can, especially on a radiograph, if the plate has moved, if there is a loose plate, you can find out that on an examination. But on a radiograph, failure of hardware is seen as radiolucency around screws. This is seen radiographically on radiograph or imaging. All right, on radiograph or imaging, this is the sign of hardware failure. Fine. Now let's come to the next question. Question 4. A patient presents to your OPD with complaints of pus discharge from nasal cavity and nasal regurgitation on intake of liquids. Gives history of dental extraction in maxillary arch 3 to 4 months back. Upon examination, you find a large orodental communication. How would you proceed? Option A is pus culture, empirical therapy, antibiotics and closure with acrylic plate. Option B is titanium mesh, closure with buccal fat pad and buccal flap. C is empirical antibiotics, surgical removal of sinus lining, closure with buccal fat pad and buccal flap. And D is pus culture, empirical antibiotic therapy, close with buccal and palatal flap. Alright, so what would be the best option that you would pick from this? Please let me know the answers. So your answers, all of you? No answers. Why? Okay. More answers. More answers. Fine. Let's see. Okay. Past discharge. All right. That means there is something infected. Nasal regurgitation. It is telling you that there is a oroantral communication or fistula. Now, history of extraction is 3-4 months back, and he's complaining of this. The patient is complaining of the symptoms since then. All right. So, what does this signify? That there is something chronic and infective. All right. So, what you will do is you have to take care of the infection. All right. And you have to close also. But in between doing all of this, you have to do another thing. You have to make sure that by this time there is too much of chronic inflammation present. So what will happen? Sinus lining will become hyperplastic. It will become inflamed, hyperplastic. So you also have to make sure that whatever features of sinusitis are happening, that also need to be taken care of. All right. So you will put the patient on antibiotics. You will remove the sinus lining. All right. And you will close with a double flap, because the fistula is long standing. It is now a fistula. It is very long standing fistula. So you will give a double layered closure with buccal fat pad and buccal flap. All right. So here your option C is the correct answer. This is your correct answer. All right. You have to take care of everything. Okay. Now coming to our next question, question 5. Complication of using air rotor at 30,000 rpm for impaction. Option A is necrosis of bone, tissue laceration, tissue necrosis, and option D is emphysema. So please let me know the answer to this question. Then I'll explain. Bhavna, question does not mention of fistula, but if you go back to my notes, any oroantral communication after 14 days, all right, any oroantral communication after 14 days will develop a epithelialized tract, which will be known as oroantral fistula. All right. So you will have to remove the fistulous tract, you will have to remove the sinus lining, and then you will have to give a robust closure. All right, because it is long standing, a double layered closure. Understood, Bhavna? Okay. Now we'll come to question number 5. C. Air rotor at 3000 rpm. Now I want to tell you, the only confusion you will have is between A and D. B is not the answer C is not the answer anyways. Alright, the only confusion will be between A and D. Now if you all have seen an air rotor, alright, the air rotor has a inbuilt irrigation. Whenever you turn on the air rotor, there is irrigation coming along with it. Alright, so and anyways, while doing an impaction, even if let us say for example there is no irrigation along with the air rotor, so whenever you're doing an impaction, you must have seen your seniors, your faculty, that there is constant irrigation while you are doing the buccal guttering or while you're removing the bone. Alright, so anyways, necrosis of bone is ruled out. Alright, necrosis of bone is ruled out. Now I'll tell you the mechanism behind emphysema. What happens is, if you compare a micromotor and an air rotor has extremely high RPM. Alright, and while doing an impaction, you are just working at the junction of the hard tissue and soft tissue, that is the bone and the soft tissue. So what can happen? Air rotor under high pressure can push large amounts of air inside the soft tissue. Alright, inside the soft tissue it can push large amount of air under pressure. So the patient will develop a swelling, and the swelling will crackle on palpating. That is a classical emphysema picture. Alright, that's a classical emphysema picture. Okay, understood, Monirudya? And other person who has answered A, I hope this is clear now. This is also known as surgical emphysema. Okay, we go to the next question. Commonest complication after removal of third molar is, option A is lingual nerve damage, B is dry socket, C is fracture mandible, D is bleeding. In pulse, it's given that above 5,000 leads to necrosis. See, the chances of it causing necrosis is still less as compared to surgical emphysema. Alright, air rotor, if you're using it for impaction, especially impaction, it is most likely to cause surgical emphysema followed by necrosis of bone. So if emphysema is present in your options, please give preference to marking emphysema followed by necrosis of bone. Alright, okay, because air rotor is ideally not the instrument used for an impaction. If you go anywhere, air rotor is not used. Even in your college, outside in private practice, air rotor is not used for this very reason, that it causes surgical emphysema. Okay, yeah. Answer to question 6. More answers to question 6, please. Now, coming to question 6. Option A, option B, option C, option D. They are all complications of mandibular third molar. Impaction, removal, whatever. Alright, they are all complications, but it is asking about the commonest complication. So the commonest complication is dry socket. if you look at the incidence of dry socket, no, it is the highest in mandibular third molars. The incidence of dry socket is highest in mandibular third molars. That is why this is the answer. Alright, now coming to lingual nerve damage is a rare complication. See, every third or fourth patient will not present you with a lingual nerve damage. Utmost care is taken during an impaction to preserve your lingual nerve. I'm not saying it does not happen, it happens. Even fracture of the angle of mandible, that also happens. Alright, bleeding also happens. Now the thing is, bleeding is something which anyways when you're giving an incision, removing an impaction, that is going to happen. Alright, so option B, dry socket, this is the answer to this question. Others are complications, but they're relatively less or they're relatively rare as compared to dry socket. Okay. Now coming to question number 7. After multiple tooth extractions, sutures are placed at interdental septum across the socket on the adjacent tooth, and option D is none. So let me know the answers. Quickly, answers to this question. Question number 7. No answers. Why? Any more answers? Okay. So you will not give sutures across the socket. You will not give sutures on the adjacent teeth, and none, that means not giving sutures and multiple extractions is not a possibility. Interdental septum is your answer. Now see, the thing is, this is a kind of a relatively poorly framed question. Ideally it should be interdental papilla or the interdental gingiva. All right. So the thing is, why are you placing your sutures which are resting on the interdental septum? That means those sutures are engaging your interdental papillae. Now your papillae are most important for aesthetic rehabilitation. All right, they'll give a good approximation to the gingiva. 1, all right, gingiva, both buccal and lingual gingiva will be nicely approximated. 2, if you have to carry out aesthetic, especially in aesthetic areas, if there are multiple extractions, so if you have to rehabilitate, so the patient will have a good contour. All right, the patient can, you can establish a good gingival contour while you're rehabilitating. Also, if you apply the sutures just across your socket, so the approximation of the interdental gingiva or the interdental papilla won't be correct if you place sutures just across the socket. So this is the reason. All right, understood? Now question 8, dumbbell shaped swelling during third molar block or PSA block. All right, this can also be framed as the other alternative. Posterior superior alveolar block is due to option A, injection in pterygoid plexus, option B, injection in parotid gland, option C, injection in internal maxillary artery, and option D, injection into nasal cavity. So please tell me the answer to this question. Yes, I know you have asked in the group. That is why. Sometimes verbal explanation is a more you comprehend verbal explanation more as compared to written explanations. That is why I'm taking this session. Okay, more options. More answers, sorry. Others, please. Shallow. Let's see the explanation. Injection into nasal cavity. You're giving posterior superior alveolar block. There's no way you can give an injection into the nasal cavity. So injection into the parotid gland will actually cause transient facial nerve paralysis. All right. It will actually cause transient facial nerve paralysis, and this is also during your inferior alveolar nerve block. And this is during inferior alveolar block. Okay. So now the confusion remains between option A and option C. Sorry. So basically, when you're giving a posterior superior alveolar nerve block, you're most likely to injure the artery. All right. You're most likely to injure the artery. Which artery? Posterior superior alveolar artery, which is a branch of the internal maxillary artery. All right. So if internal maxillary artery is given in your options, you will prefer this. If this is not given in the options, then you will mark pterygoid plexus. Both are correct. A and option C, option A and option C are correct, but preference to be given to internal maxillary artery over pterygoid plexus of veins. Okay, is it clear? All of you? I hope this question is clear. Now, please let me know, then we'll move forward. Yes, very good. Now, question 9. Ligamental injection of 2% lignocaine with adrenaline will cause the pulp circulation to A. Cease for about 30 minutes, B. Remain the same, increase, C. Increases markedly, and D. Decreases slightly. So, I need your answers, all of you. So, what will be the answer to this? No answers? More answers? Any more answers? So now let's understand the question, okay? Ligamental injection. This is nothing but your intraligamental injection. This is your, basically you're injecting LA into the PDI. Okay, now 2% lignocaine with adrenaline. So there is a vasoconstrictor. Okay, the question has mentioned a vasoconstrictor. So let's rule out the options which are just not possible. Remain the same. That will not happen because there is vasoconstriction. Increases markedly because there is a vasoconstrictor being used. Now the confusion remains between option A and option C. Seizes for about 30 minutes. This is also incorrect. See, the pulp, in spite of the fact that the pulp vessels or the pedal vessels are small, they are very tiny, but the blood flow or the blood supply will not cease completely. Alright? Otherwise, the tooth will become non-vital. So, it won't cease, but it will slightly decrease. Alright? It will slightly decrease. The blood flow to pulp is not going to stop. Okay? It's only going to decrease slightly. Fine? Because only vasoconstriction is happening. Understood? So, coming to the next question, that is question 11. In 2017 tumor classification, which of the following is removed? Option A is calcifying odontogenic cyst, ameloplastic fibroma, ameloplastic fibrodontoma, and odontogenic keratocyst. Fine. See, I do not know why this question has been asked, because to know this question you have to remember the entire classification of odontogenic cysts and tumors both. If option A is given, that is incorrect, Monirudaya. You can correct your answer. All right. So yeah, coming back to this question. In 2017 tumor classification, to be able to answer this question, you are supposed to know the classification of cyst and tumors, which I feel to retain the classification is little difficult. I have anyways mentioned the classification on the next slide. You all can go through it later on, but the answer here is ameloplastic fibrodontoma. This was removed in the 2017 classification. This is the answer. So this is one of the factual questions where you have to remember your classification. So I'm just scrolling up to the classification, WHO classification. You can take a screenshot of this, or I will post the classification on the group later as well. Okay. Fine. All right. This is the classification. Now let's scroll to the next question. Least preferred method for treatment of unilateral TMJ ankylosis. Question number 12. Option A is temporal fascia, B is condylar shave, C is contralateral condylectomy, and D is ipsilateral condylectomy. Alright. So you let me know your answers. Although this is a very, very absurd question. I do not know why and how this question has been framed, but we still have to pick the best answer amongst the given options. So please let me know your answers. Least preferred. Please see this word. Can you all let me know the answer for this question? And unilateral TMJ ankylosis. More answers. Okay. See, so it is saying least preferred and for unilateral TMJ ankylosis. All right. This is ये ना बेवकूफ बनाने वाला क्वेश्चन है, ठीक है. All right. So the answer is contralateral condylectomy. I'll explain why. It is a case of unilateral ankylosis, TMJ ankylosis. तो जिस साइड ankylosis होगा उसी साइड का आइडियली कॉन्डाइलेक्टमी नहीं होना है, बट अगर होना भी है तो उसी साइड का होगा. ओके. There is no question of contralateral anyways. Condylectomy, there is no question. Coronoidectomy, contralateral, yes, you may consider if you're not able to achieve a mouth opening. So please understand the difference. Contralateral condylectomy does not solve your problem. Alright. Contralateral coronoidectomy might still solve your problem of a adequate mouth opening or interincisal opening on the table. But contralateral condylectomy plays no role in a unilateral TMJ ankylosis. Ideally, condylar shave is also not to be done. So the confusion remains between B and C, but if I have to mark, the better option is C, contralateral condylectomy. All right, this word. Understood, everyone? Now coming to question number 13, if fracture of mandible occurs distal to last tooth, the treatment choice is closed reduction with IMF, open reduction with bone plating, open reduction with interosseous wiring, closed reduction with cap splint. I need answers now from all of you. For question 13. More answers so that we can discuss. Okay, now I'll explain. So fracture of mandible distal to last tooth. Distal to last tooth is actually your angle fracture, right? So most of you have got this question right. So whenever it is distal to the last tooth, conservative options become like your conservative options are basically omitted. You cannot do those. So closed reduction with IMF is not possible. Closed reduction with cap splint is not possible. All right. Fine. Now, open reduction with interosseous. This is a semi-rigid, a non-rigid fixation. All right. So this is also omitted. Open reduction with bone plating is the correct answer. Fine. So all of you have got this question correct. Very good. Now coming to question 14, treatment of choice to manage symphyseal fracture in an 8-year-old child is no treatment indicated. That is option A. Option B is cap splint with circumferential wiring. C is open reduction and D is intermaxillary fixation. Please let me know the answers to this question. More answers. Okay. So it says a symphyseal fracture in an 8-year-old child. ठीक है? Fine. Now, we all know symphysis. If we see for adults, we will just do a little correlation over here. If we see for adults in symphysis fracture, what is going to happen? There are going to be torsional forces. Alright, there are going to be torsional forces. That's why in adults, according to Champy's lines of osteosynthesis, we give 2 plates for a symphysis fracture. Now here, alright, I'll first tell you the answer and I'll also tell you what can be the other scenarios. Cap splint with circumferential wiring would be your answer over here. Keeping in mind that there's the symphysis fracture and they can be torsional forces. Now, you do not do IMF for a child arch bar. Usually you do not do it, but if the need arises, you can do it. Now, had the question said undisplaced fracture, alright, or no grossly deranged occlusion, in that case, yes, no treatment can be your answer. Fine. Now, if that would have said, if the question would have mentioned deranged occlusion, then you would go for open reduction and internal fixation. Okay, and maybe IMF or whatever after that. So, but since considering it to be a symphyseal fracture with some torsional forces and with no other information provided in the question, circumferential wiring and splint is your best answer. Alright, fine. Okay. So Vivek, C, to prevent gonial flaring. In that case, they would have mentioned that there is a lingual splay, or they would have mentioned things like that. All right, that there is increase in intergonial distance or increase in facial width. They would have mentioned. In that case, yes, if that is also mentioned, you can go for open reduction internal fixation. All right, is it clear, all of you, how to approach these questions? We'll go on to the next. Now again, question 15, fracture of body of mandible with full arch of teeth is treated by undisplaced. Now this can be undisplaced teeth also and undisplaced fracture. So if teeth are undisplaced, that means fracture is also undisplaced. So option A is IMF, B is external pin fixation, C is closed reduction and internal fixation, and open reduction and internal fixation. So what would be your answers? Please tell me your answers. No, you don't have to consider deranged occlusion if nothing is given. If the question will mention if there is deranged occlusion, all right, the question will mention, or there will be some clinical symptom or sign given, like a open bite, cross bite, something will be given which will signify deranged occlusion. If it is not mentioned, you don't have to consider deranged occlusion. Okay, Vivek? Yes, question 15, answers please. More answers. Fine. So basically, this is again another absurd question. Basically, so first, let us rule out our options. All right, the options which are just not possible. External pin fixation. This is not possible. All right. Now, careful. Option C, closed reduction internal fixation. There is closed reduction and IMF is possible, but closed reduction and internal fixation is not possible. Internal fixation is your use of plates and screws. So without exposing the fracture site, how can you use plates and screws? So closed reduction, internal fixation is nothing. Okay. Fine. So now the confusion remains between option A, that is IMF, and option D, that is open reduction and internal fixation. All right. So here you can go with option A because it is saying a undisplaced fracture. Full arch of teeth, full set of teeth are present, and it's a body fracture. So body fracture, if you see Champy's line of osteosynthesis, there is only one plate that you use for a body fracture. All right, via your Champy's line of osteosynthesis, you use a single plate on body fracture. So that means you can manage this fracture via IMF because the question clearly mentions it is an undisplaced fracture. All right, so this would be the answer. Undisplaced fracture. Understood all of you? Option C वाले सबको समझ आ गया? Now, question 16, a fracture of mandible should be immobilized for an average of 3 weeks, 6 weeks, 9 weeks or 12 weeks. I have taken this in the revision express also. All right, detailed explanation in the class and in the revision express also. So let me know your answers, and I have put the rules of IMF in the next slide. You can quickly go back to the explanation in the revision express and understand this question. So let me know the answers quickly. Answers, please. So the average is 6 weeks. All right, average is 6 weeks. Okay, these are the rules of IMF. Okay, so it says young adult with fracture of angle receiving early treatment in which tooth is removed for fracture line. The immobilization or IMF is for 3 weeks. Okay, tooth retained in fracture line is plus 1 week. Fractured symphysis is plus 1 week. Age 40 years and more is plus 1 or 2 weeks. And children, you subtract 1 week. Now, the ideal scenario now comes: a 40-year-old patient with symphysis fracture whose tooth in fracture line was retained. What would be the duration of IMF? So your 3 weeks is your baseline. All right, you add 1 week for fractured symphysis, and you add 1 week for tooth retained in fracture line, and you add 1 week because the patient is 40 years. All right, 40 years. So this makes it 6 weeks. This was the average calculated by Killian K. All right, by Killian K, this was the average that was calculated. Now 40 years, 1 or 2 weeks, how do you decide on this? Quickly, I'm telling you. So it's just 40-year-old patient between the range of 40 to 50. You will add 1 week. If the patient is more than 50 years of age or more than 40 plus systemic illness or any comorbidity, you will add 2 weeks. Okay, understood rules of IMF, everyone? Is it clear? Now, question 17, treatment of sagittal split condylar fracture. Option A, no treatment. B, ORIF. C, reduction for 4 weeks plus physiotherapy. D, reduction for 4 weeks and elastic guidance. Quickly answer to this question. Okay, good. Answer to this question. Okay, these pictures that I've shown you, this is a sagittal split. All right. Okay, if you see the condyle from the front, all right, if you see the condyle from the front, this being the medial side, this being the lateral side, medial, lateral. So any fracture like this in a sagittal plane, all right, in a sagittal plane, this is a sagittal split fracture. All right, now you cannot really do any plates or screws, because the thing is, you always plate on the, if you remember my class, I have told you, you plate on the lateral aspect and one plate towards the anterior border and one towards the posterior border. Okay, either laterally, if you will see from this lateral aspect, you won't see any fracture, you will just see maybe some one crack over here. So ideally plating is not possible for a sagittal split fracture. What is possible is you put the patient in IMF, reduce and put the patient in IMF. This is the treatment for a sagittal fracture. Or if not this, then yes, lag screws is definitely possible. Lag screw in such cases is definitely possible. You can drill a screw from the lateral aspect, okay, and the screw will hold. All right, you can drill a screw from here. A lag screw is definitely possible, but plating is not possible. So let's go back. You rule out option A and ORIF. All right, so now the confusion remains between options C and D. Reduction for 4 weeks and physiotherapy, and D is reduction for 2 weeks and elastic guidance. So the better option here would be reduction for 2 weeks and elastic guidance. Elastic guidance is nothing but your IMF to guide the occlusion or to prevent occlusion from getting deranged. Okay, understood all of you? Reduction for 2 weeks and elastic guidance. This is your answer. Or if specifically a lag screw is mentioned, that would become your best answer. Okay. Now coming to question 18. In body fracture of mandible, mini plate is given at A, superior border, B, lower border, between upper and lower border, and one at upper and one at lower border. What would be your answer over here? Quickly let me know the answer. Come on, quickly, answers please. This is also an important question. Others, answers. Okay. So the question says fracture of body of the mandible. Again, go back to your Champy's line of osteosynthesis. It says single plate on the body. All right. Now, see, you are giving a single plate and where are you supposed to plate it. So now option D is anyways ruled out. One upper, one lower is ruled out. According to Champy's principles, body requires only one plate. Okay. Now, now we have to decide between option A, B, and C. Okay. Superior border is ruled out because you will encounter roots. Okay. Lower border is ruled out because it will cause splaying or opening up of upper border. Superior or upper border, whatever. Alright. So the best place is in a neutral position between upper and lower border. Single plate between upper and lower border. Alright. This would be the best. Fine. Is it okay? Understood, everyone? Why is it option C? So question 19, suturing of facial injury should be done within A 2 hours, B 6 hours, C 4 hours, D 8 hours. Alright. So I will again remove a confusion for once and for all. The answer is 6 hours. Somewhere it is given wrong. Please correct. No doubt about this answer. Alright. 6 hours. Okay. Suturing in facial wounds. Now, question number 20. Which of the following areas called a key area for orbital reconstruction? A. Anteromedial wall, B. Posteromedial wall, C. Anterolateral wall, and D. Posterolateral wall. Okay. Now, this is another postgraduate level question. Fine. So I actually cannot expect you all to know this question. Fine. I'll tell you the answer and I'll explain you also. So the answer is posteromedial wall. Now let us understand why. Okay, so I have two visuals over here. See, these pictures are telling you the proper ideal anatomy or how the orbit ideally is in everyone. So if you see from a sagittal section, this CT scan, this is your infraorbital rim. There is a dip as you go posteriorly in the orbital floor, and then there is a upward elevation in the orbital floor. So basically the orbital floor is like a gradual S. Okay, there's like a gradual S. If you see from the coronal section, this contour, medial, posteromedial, this contour. This is how the contour is posteromedially of the orbit from the coronal section and posteromedially from the sagittal section. This. It is important to maintain this contour because this gives the shape of the orbit, maintains the volume of the orbit, and maintains the globe maintains the orbital contents in its actual position. Alright, if you reconstruct it in this way, your orbital levels will move down. Okay, so this, to restore this contour, to maintain this contour, is the key to orbital floor reduction, and this is more important. Please remember this concept. It is a postgraduate level concept ideally, so don't need to go into many details. Okay. Now, the Coming to question 21, early removal of or germectomy or lateral trephination technique. What is the purpose of leaving behind a 5 cup of attached gingiva? Okay, options are to enhance aesthetic appearance. Option A, to facilitate suturing and healing. Option B, to prevent damage to adjacent second molar. To allow for easier access for future procedures. So quickly, everyone, tell me the answer to this question. Okay. Tell me the answer to this question quickly, all of you. Okay, so we know lateral trephination technique is usually done for teeth whose root apices are still not closed. All right, so it is a third molar region. Aesthetic से कोई लेना देना नहीं है. Okay, there's no need to do anything for aesthetics. And D, option D, to allow for easier access for future procedures. Mucosa heals very well, so there's no question of aesthetics or sorry, no question of ease of access or anything. This is also out of question. Now, option B, to facilitate suturing and healing, is also correct. Option D, to prevent damage to adjacent second molar, is also correct. Now, this 5 cuff of bone, this is basically what this does is, this prevents bone loss around second molar. All right, this actually prevents bone loss around second molar and also facilitates healing. Okay, but if you have to choose between B and C, please go for option C followed by option B. All right, it prevents damage around second molar, it prevents bone damage, it prevents pocket formation. Okay, now again, question number 22. The greatest barrier to infection is connective tissue. A, connective tissue. B, epithelium. C, muscle. D, fascia. Okay, I am going to tell you the answer. It is given wrong everywhere. Answer is the epithelium. Please follow this only. You don't need to follow anything else. Greatest barrier to infection is epithelium. Pass. Single one-liner question. No two thoughts about it. If it's given anywhere as fascia, please correct that. Now, I'll read out question number 23 and I need answers from all of you. So, cavernous sinus thrombosis following infection of anterior maxillary teeth most often the spread of infection is along A, facial artery, B, ophthalmic vein, C, angular artery, D, pterygoid plexus. So quickly, I want answers from all of you. I want you people to answer this question. Then I will explain. Everyone else? Others? Okay, very good. I'm very happy that you've got this question right. Ophthalmic vein is the correct answer. See, cavernous sinus, from please remember, anterior route is through superior ophthalmic vein. And posterior route is to pterygoid plexus. Alright, and question mentions anterior maxillary teeth, so option B is your answer. Understood? Neha, have you understood? Okay, I have noted your request, Vivek. We will have more sessions like this. Okay, Neha, is it clear, this question? Which of the following facial bones, question number 24, offers least resistance to impact forces? A. Zygomatic arch, B. nasal, C. maxilla, D. mandible. Okay, very good, Monirudha. Please tell me the answer to this question quickly. We are just remaining with one couple of more questions. Then we'll wind up the session because you have another session also. Okay, yes, the correct answer is nasal. Okay, don't panic by seeing a question like this. This is basically a repeat question, बस उसका वेशभूषा बदल दिया है. Language इतनी fancy कर दी है that students get panic. The examiner has achieved its motive of making the students mark the wrong answer. Facial bone offering least resistant to impact forces is basically nothing but the other way of saying which bone is prone or which facial bone is most commonly fractured. All right. Now, question 25. A woman with hypertension on medication and good control clinically underwent an extraction. However, she collapses upon getting up from the chair. What is the most probable cause? A. Hypoglycemia, B. Orthostatic hypotension, C. Adrenal insufficiency, or D. Stroke. So, quickly tell me the answers. Okay, see, we will rule out hypoglycemia. Alright, nothing like diabetes, anything is not given in our option. Alright, we will rule out adrenal insufficiency. Koi history of steroid intake or adrenal gland suppression is nothing is mentioned. Hypertension on medication, good control. That means it is a good, well controlled systemic disease. All right. So, even stroke we can rule out. Now she says she collapses upon getting up from the chair. All right, you must have seen in your clinics, you have done an extraction, patient gets up, the moment patient gets up, just falls down on the float dhadam karke aise. So that is orthostatic hypotension. Now just understand the mechanism behind this quickly verbally. Okay, what is happening is the patient is in a supine or lying down position, okay, and is undergoing an extraction. It is a stressful procedure. So what is happening, the patient's body is readying itself, for a fight and flight response. So for that fight and flight, what will happen, the patient's body is readying itself to run. So there is pooling of blood in lower extremities. Vasoconstriction नहीं हो रहा है lower extremities में, so the blood flow to the upper part of the body is less. Alright, and in such a scenario there will be vasoconstriction or return of blood from the lower extremities to the upper circulation. Hence, what will happen, as soon as the patient gets up, the patient will fall or the patient will collapse and become unconscious. That is orthostatic hypotension. No, there is no, Alia, there is no chart when to use Riston wiring, Essex or Gilmer's. Few indications I have given in my notes, just those are enough. Alright, just those are enough. Now, our last question for today, question 26. A polytrauma patient brought into the emergency on stretcher with a cervical collar in place. On examination, the patient is unresponsive to painful stimuli, verbal commands. What would be your first action? A. Option A, CT scan head and cervical spine. B. Tracheal intubation with cuffed tube. C. Oropharyngeal airway. D. CT scan head, face, cervical spine, chest and abdomen. See, if now Vivek, if they would say poor hypertension, first of all, ideally a extraction should not be done. Okay, and even if they mention that there is like patient has taken medications, however there are episodes that the patient, if they may mention that patient is on medication but patient still complains of some spike in BP or some episodes of high BP in between taking medications also, then you can consider stroke in your answer. Alright, then you can consider stroke in your answer. But with stroke there would be other things mentioned like slurring of speech, weakness of limbs, and then followed by collapse. Alright, okay, so yeah, the correct answer here is tracheal intubation with cuffed tube. This is the answer. Okay, now Anand, okay, why option C, oropharyngeal airway, is not the answer? Listen to me. It is saying that the patient is unresponsive to painful stimuli, verbal commands, and patient is unconscious. So the GCS is 3. Alright, patient is unconscious, patient is a comatose patient. Alright, so in this kind of a patient we will go in for a definitive airway, and that is your intubation, tracheal intubation with a cuffed tube, because we do not know for how much time the patient will be comatose. Alright, understood, Anand? So this is the end of our session. Okay, I want to tell you all not to panic while answering your questions. See, most of your questions are answerable from your theory. Alright, I'm not saying this only for oral surgery, I'm saying this for all subjects. Most of your answers, examiner का काम है answers को घुमाना, but if you remember your notes, if you remember your theory, just correlate your given scenario with your notes. Be thorough with your notes, revise. You have time, dates have not been announced yet. Even if dates are announced tomorrow, you will have at least 2 months. Okay, so just relate everything with your theory, notes and then go and answer. In case if you still feel that you're going wrong, just go back to that topic, revise the theory, and then again proceed with your, all right, then proceed with your other options or your questions. Okay, how GCS will be 3. All right, so if you remember in my class, GCS is calculated by EBM, best eye response, best verbal response, best motor response. All right, so here it is saying the patient is unresponsive to verbal commands and to painful stimuli. All right, so in the least response is given scored as 1. All right, scored as 1, no eye opening on either on painful stimulus or on calling out. All right, that is 1. There is no motor response. You are asking the patient, lift your hand, lift your legs. There is no response. You are giving a verbal command to the patient, that is not responsive. You are giving a painful stimuli to the patient, that is also not responsive. So the GCS will be 3. All right, Anand, you can go and revise GCS. If there is any doubt, you can ask me in the group. All right, so this is it. Let us wind up our session. All the best. Happy studying. Thank you.